All right, this is part 5 of the series on cardiovascular disease, and here we're going to focus on, this will be the first video on cardiac diseases. So I'm going to talk first about the whole, about chest pain, when it presents in the clinic, what we need to think about, kind of what some of the differential diagnoses are with chest pain. Then I'll focus on ischemic heart disease and talk a bit about angina and myocardial infarction, and then we'll end on heart failure. So I want to say a few words about how to approach or think about a patient who presents with chest pain. This is always something we're concerned about because some of the causes of chest pain can be life-threatening and need immediate referral. So there can be conditions like a myocardial infarction, unstable angina, aortic dissection, pulmonary embolus, tension pneumothorax, or esophageal rupture. Those would be our most concerning causes of chest pain. But we want to kind of think through clinically when a patient presents what might be the main origin of their pain and then make appropriate referrals as needed. So to do that, we need to be sure to get a very complete history. Now, again, if a person presents acutely with chest pain, they're in distress, respiratory distress, it's going to be hard to get a history. And those are the patients, of course, we refer immediately to the emergency room, usually call 911. But if a patient, presents maybe with acute onset chest pain, but they look like they're stable, their vitals are stable, and so forth, then we can maybe elicit more of a history from them. But we want to gather information about the character of their pain, the location, the severity, duration, radiation, and then any aggravating or relieving factors. So classic cardiac chest pain would be typically worse with exertion, worse with activity, and better with rest. Now, that's not going to be the case for all cardiac chest pain, but that's the typical pattern, for example, with stable angina, that sort of thing. We have to look at the patient's history. Do they have a history of cardiovascular disease? What are their atherosclerotic cardiovascular disease risk factors that we spoke about a few videos back? Have they had any prior procedures, any other workups like stress tests, echoes, angiograms, stents, the percutaneous intervention, or have they had a CABG, a coronary artery bypass graft, open heart surgery in the past, and any history of known angina? We want to, of course, gather in the clinic their vitals, and we want to do a cardiopulmonary exam, abdominal musculoskeletal exam. Again, if you're not a primary care physician and not acting in that role, then this would not be applicable. But at the very least, gathering vitals would allow you to assess get a little bit of an indication of the severity of the pain and whether or not it's affecting vital functions. Typically in a primary care, or if the patient's been referred to the emergency room, they would gather, basic labs, CBC, CMP. We look maybe at some of their cardiovascular risk factors. So this is going to be more for maybe follow-up care, but things like their A1C, lipids, thyroid. An ECG should be obtained in nearly all cases of chest pain. And then cardiac enzymes could be important if a MI was suspected. And that would be specifically the cardiac troponins and the creatine kinase fraction MB. So these would be what's called the cardiac enzymes, and it's a panel that would be run. And together with the ECG, that has a pretty high sensitivity and specificity for identifying myocardial infarctions. Chest radiograph also is important in nearly all cases to rule out pneumonia, any masses, etc. And then possible echocardiogram to look at heart function in more detail. And then we would look at all the risk factors in history and think of a diagnosis. Now, the first thing we should say, of course, with chest pain is we have to differentiate it if whether or not it is acute or chronic, obviously. So I'm going to focus more on acute chest pain here. Chronic chest pain can be related to many of these different disorders, but this is something typically a person has, had for many years, and they've often had workup previously and so forth. But with acute chest pain, that's where we're going to kind of put our emphasis. So the quick way to think about chest pain is to kind of just go through all the possible systems that could be involved. And the main ones would be the heart itself, so cardiac causes, and that could be of the heart or the pericardium, or potentially vascular causes like an aortic dissection. So we look for the different types of angina, and I'll talk about those here in this video. We'll be looking for a myocardial infarction, and that's what we're going to talk about in this video as well. Pericarditis, we'll talk about that in the second video, and we already talked about aortic dissection in previous videos. It could be pulmonary, so this could be a pulmonary embolus. It could also be a pneumothorax. It could be pleuritis, just general pleuritic pain. Pneumonia. It could be asthma, status asthmaticus. So we look at our pulmonary, do our cardiopulmonary tests. We look at pulse ox, all those things to help us decide if there's a pulmonary etiology to the chest pain. And then it could be gastrointestinal, so things like reflux, GERD, diffuse esophageal spasm, peptic ulcer disease, or esophageal rupture. It could be a chest wall issue. This is a pretty common cause of both acute but also chronic chest pain, is Castrocondritis, for example, and that's inflammation where the ribs join the sternum. A lot of people think they're having a heart attack. It's a very severe, intense, stabbing, boring pain, but it's not, it's basically worsened with any motion. It's better rest, so that's similar to a kind of a cardiac cause, but it's very tender when you press on that area, and that's not going to be typical of a heart attack. So I've had a number of those patients where we were able to figure out that this chest pain was from Castrocondritis. Could be from muscle strain, rib fracture, shingles outbreak, herpes zoster, or thoracic outlet syndrome. It could also be psychiatric, and this is always hard when a person's having a panic attack to decide, okay, is this more of a lesional problem like an MI or pulmonary embolus, or are they just having a panic attack? I shouldn't say just having a panic attack, but the panic attack is not associated with any structural damage. Of course, it's very distressing for the patient. And then anxiety, somatization could be possible as well. So these would be potential psychiatric causes of chest pain. And then different drugs like cocaine or any stimulant can actually mimic symptoms like an MI or angina. So this is kind of what we quickly think through clinically. Again, if you're not in a primary care setting, if you're adjunctive care like acupuncture, you can still think through this list and, of course, make appropriate referrals as needed. So that's the biomedical approach to chest pain. We'll focus in this video on some of the cardiac causes of chest pain and talk about them in more detail. From the perspective of Chinese medicine, chest pain is also known as thoracic B. B are different pain syndromes, so Zhongbi. And this is really pain patterns characterized by oppression of the chest with chest pain and so forth. So basically, when we see this description in Chinese medicine, we still have to think through biomedically, what are the potential most serious causes of chest pain, as I just reviewed, and then when do we need to make appropriate referral in those cases. But typical patterns of chest pain would include blood stasis, and that's really going to be the pattern associated with atherosclerotic cardiovascular disease, so ASCVD. So all those, the issues with thrombosis and atheroma formation, endothelial dysfunction, this would all be part of blood stasis. And there are very specific herbal therapies for that. Again, this would be more for chronic cases, patients that are stable, that are probably being co-managed with a primary care physician or maybe cardiologist, and that's where you might think about adjunctively adding in some of the blood-moving herbs. One thing I will say, if they are on any anticoagulant therapy, like warfarin, and they're getting their INRs measured, again, I mentioned those have to be measured sometimes once or more times a week. If you make any herbal adjustments, they're going to have to measure their INR more frequently because it will change it. We have to be very careful about when we add in therapies, and they're already on a whole list of medications, the different drug-herbal interactions, and anticoagulation is one of them. So that is the blood stasis pattern. Phlegm turbidity. This pattern I would associate more with increased insulin and insulin resistance. And so this is a pattern we might see with type 2 diabetic patients. But this basically would have more of, symptoms also of kind of respiratory mucus and whatnot. There's probably some component of asthma here as well. And so this would be more from a pulmonary cause, not just cardiac. Congealed yin cold. This one could be due more to, again, more asthma, more mucus in the lungs and so forth. We might think of more getting into the realm of a little bit of early heart failure as well with yin cold congestion. So these would be some excess patterns of chest pain. But then our deficiency patterns would be our heart and kidney yin deficiency, qi and yin deficiency, and yang and qi deficiency. We can think of, again, the qi as the autonomic tone into the heart and the chest organs. So we're going to see potential imbalances there, and that might be associated more with anxiety and panic attacks and so forth. And it might contribute, in some cases, to arrhythmias, usually benign arrhythmias, and we'll talk about the different types of arrhythmia in the next series of videos. But then yang qi deficiency would be more of low androgens. So decreased androgen pattern, and a yin deficiency would be a decreased estrogen pattern. So that might be something you see after menopause in females and so forth. So that would be just some of the classic patterns associated with chest pain. These, again, in the therapeutic order, would fall into the level 2 therapies. So as we go through each condition and I talk about the therapeutic order, this would be something to think about with the level 2 therapies. So the first and probably the most common cardiac condition is coronary artery disease. This is part of what's known as ischemic heart disease, and we talked about this in the context of atherosclerotic cardiovascular disease. So we have all these different acronyms. They're all kind of referring to the same thing. This is the leading cause of heart disease and death in the US. So higher the death rate from coronary artery disease and MIs is higher than from cancer. And it results basically, we think, when the blood flow through the coronary arteries becomes deficient, either because of impaired myocardial, the coronary artery blood flow due to atherosclerosis. So we get greater than a 75% occlusion of a coronary artery, and then often a thrombus might form on top of the atheroma, as we discussed previously. And that can cause immediate blockage of that vessel, and then all of the perfusion bed of that vessel is affected. Remember that we have 3 layers of the heart. So I'll review them here again. We have the endocardium, which is the very inside layer, and that layer can be directly nourished from the blood itself. So oxygen and nutrients from the blood, and this is of course made of endothelium. So that is endothelium, and this is known as the endocardium. So that is the first layer. Then the next layer would be the muscle layer, and that is the thicker layer. That's the myocardium itself. And if we look at the ventricular wall, it's of course very thick. And then we have the pericardium on the outside. The pericardium, remember, is 2 layers: a visceral layer and a more parietal layer, and then there's some lubricating fluid between the two. So the blood vessels, the coronary arteries, come off the aorta right close to where it exits. Remember, there's a right and a left coronary artery, and they feed both halves of the heart. And these vessels come down through the pericardium, and they actually plunge down into the myocardium, the heart muscle itself. So it feeds all of the myocytes, cardiac myocytes. There's an area, though, down here towards the bottom, the so-called subendocardial zone, which is very susceptible to ischemia because basically if we have an occlusion of the blood flow up here, maybe there'll be some blood getting through and the upper layers of the myocardium will get nourished, but this lower or subendocardial region is very susceptible to ischemia. It can't really get nutrition from the blood itself in the heart chambers, and it's not going to get it from the coronary artery. So we'll see there's actually, when we talk about myocardial infarction, remember an infarction is the actual death of cells due to ischemia. One of the most common places for infarction is in this red zone, the subendocardial zone. The next most common area would be the entire wall of the myocardium, and that is known as, that's going to be a transmural MI, and that's going to go through the entire wall, and that is that's much more associated with unfavorable outcomes, with death, and with potential cardiac rupture through the wall itself. So that's the coronary blood flow. As I mentioned a few videos back, there's some speculation, or there's some theories that basically this idea, this coronary artery obstruction theory, may be a little outdated. The thrombi, one argument is the thrombi we can see on autopsy that have formed in the coronary arteries actually form after the MI, they're not the cause of the MI. And the hypothesis instead is that it might be a massive sympathetic outflow, too much sympathetic dominance on the heart muscle, and that causes an increased oxygen or decreased ability of the myocardium to actually utilize oxygen. And as a result, the myocardium undergoes ischemia and then potential infarction. But either way, the myocardium is definitely not doing aerobic metabolism appropriately, and that's what results in the eventual infarction. So that's one theory, is the impaired blood flow through the coronary arteries. The other is the other theory around what gives rise to coronary artery disease is myocardial hypertrophy. And so as the myocardium is the ventricle wall, for example, hypertrophies, grows, it's going to have a greater demand for blood supply. And this is typically associated, as we saw, with chronic hypertension. So that's going to predispose you to coronary artery disease or an ischemic event in the heart. So the clinical syndromes related to coronary artery disease would be angina pectoris, and this basically is cardiac muscle pain from ischemia, but not from infarction. So the heart muscle has not died, but it is getting ischemic, and that's triggering pain nerve endings to fire, and so you get chest pain. So we'll talk about angina pectoris. Myocardial infarction is now when we have an actual death of the heart muscle. There is a type of angina called unstable angina, which can progress into an MI. And then we have what is called a non-STEMI, non-ST segment elevation MI. Remember, the ST segment is something we see on the EKG. And when that segment is elevated on an EKG, when we have what's called a STEMI, an ST segment elevation. So you can have an MI without ST segment elevation or with. Typically, the MIs without ST segment elevation are going to be occurring in that subendocardial zone. So this would be a non-STEMI typically, and a STEMI would usually involve the entire ventricular wall. So that's getting more severe and more serious. Sudden cardiac death is another type of ischemic heart disease. And then chronic ischemic heart disease with congestive heart failure would be another variant there. But we're going to talk about these first two, angina and myocardial infarction. Now, cardiac muscle death occurs when there's decreased ATP and there's a cessation of the aerobic glycolysis. So basically, when the cardiac muscle cells break down glucose into pyruvate, it can be used in two ways. One is anaerobically, it can be made into lactic acid. That's called anaerobic metabolism, but that makes very little ATP. The other is that it goes into the mitochondria, the pyruvate goes into the mitochondria, and from there it makes ATP, large amounts of it, but it requires oxygen. So what happens in myocardial infarction or even ischemia, is decreased ATP due to a cessation of aerobic metabolism. The myocardium can withstand brief periods of ischemia, but after a time, it doesn't. So it builds up all sorts of free radical damage and wastes and whatnot. And so even if that cardiac muscle is reperfused, it fails to properly function and it dies. So that results in myocyte necrosis. The causes of ischemic heart disease are the ones we already reviewed, all the ASCVD risk factors. And calculation of the ASCVD 10-year risk score can kind of give you an estimate of what a person's risk of an ischemic, or what their risk of coronary artery disease might be. So the assessment, again, if you suspect a patient's having an MI, you need to refer them to the emergency room immediately. Just call 911. But basically, we're going to, for patients presenting again with chest pain, we're going to get the full history, including their family history, identifying CVD risk factors like smoking and their exercise and diet. Going to do our physical exam, definitely checking vitals. So you're going to check your blood pressure, your heart rate, respiration rate, as well as oxygenation with the pulse ox, and then do a full cardiopulmonary exam, heart and lung exam, maybe peripheral artery exam, looking for any bruits in the carotid arteries that might suggest atherosclerosis. Typically, we don't do that, especially in the acute sort of settings. And then labs, typically, as I mentioned, I already went through these, but all the ones that would help us kind of identify a person's cardiovascular risk. So the first thing that's usually done when the patient goes to the emergency room, and again, don't send the patient to urgent care. Urgent care isn't equipped to really deal with this. They have to go to the emergency room. So they're going to get a resting ECG, and usually they're normal in a lot of cases, especially when the patient is not in pain. So they're going to be more accurate if the patient is actually having chest pain. And so there, the ST segment elevation might be evident. And then what are the T waves? Remember, they come after the QRS complex. The T waves usually are upright in most of the leads, and they go inverted. And so that would be a T wave inversion. So those would be indicators of myocardial infarction. A stress test might be given not in the urgent care or the emergency setting, but again later if a person presents with chest pain, we think it might be angina. We might go ahead and do a stress EKG, and that's where they're on the treadmill, and then you start to see the significant ST segment changes. A stress echo might be useful, especially if there has been a transmural MI to assess the cardiac muscle and so forth. And then nuclear stress testing and coronary angiography. The angiography would be the most sensitive and specific test for coronary artery disease. And that's often done right before, and that could be done with the procedure that places a stent in the coronary artery. So this would be the assessment for ischemic heart disease, and this would include angina, not just MI. So not all these patients are going to come in with acute chest pain. But your classic angina case might be, I get pain on exertion, better at rest. I've had it for the last 5-6 years. It doesn't seem to be worsening, but these would be some of the tests we would run to assess that patient. If they're having the acute chest pain, they're in acute distress, rapid pulse, their blood pressure is falling because of lower cardiac output, etc. That's an emergency, that's 911. So that's a little bit about the assessment for ischemic heart disease. So I'm going to talk first about angina. This is chest pain caused by myocardial ischemia, not infarction. And the most common form is stable angina. And this is basically resulting from severe coronary artery disease and atheroma formation. But usually the plaques are what we call stable plaques. Remember, we have two different types of plaques. The stable ones are slow growing. They become calcified over time. You often get collateral circulation around them, and they tend not to rupture. And so it's unlikely that they'll form thrombi on top of them. The other type of plaque would be a friable plaque, and that's a plaque where the covering on top of the atheroma ruptures, and so that causes platelet aggregation and triggers all the events around thrombosis, and that will be part of unstable angina. We'll look at that here next. Usually in stable angina, multiple coronary arteries are involved, and for some, over time, this chronic ischemia can evolve into congestive heart failure, so there is a complication there, but these cases tend not to evolve into an MI. So that's the good thing about stable angina. It presents as substernal chest pain, worse with exertion, stress, cold, or heavy meals. That's an interesting one. So when you eat meals, that basically is going to increase your parasympathetic responses. It's going to kind of draw all the blood down into digestion, and in a way that's going to put a greater demand on the cardiac output to sort of maintain that splanchnic circulation. So that can trigger angina. Typically, stable angina is better with rest. And it is better with nitrates, especially nitroglycerin. Remember, that is a vasodilator. So when they take nitroglycerin sublingually, it causes an immediate dilation of their coronary arteries and they feel better. And that's the typical idea. I had one patient with stable angina. He got it every time he would go walking up a hill, and he found that if he took a shot of tequila before he went, that actually solved his angina. Um, so anything that causes vasodilation would make stable angina better. Typically, the episodes last 10 to 15 minutes, usually a little bit shorter. There's a sense of heaviness, pressure, squeezing in the chest. Rarely the pain is sharp or stabbing. That might be more indicative again of things like, costochondritis or potentially aortic dissection. And the pain is often gradual in onset, and it's not associated with a change in body position. So you move the chest, it doesn't worsen or lessen the pain. The pain pattern again is beneath the sternum, might radiate to the left jaw and the arm. So this is a typical presentation of stable angina in males. We have to be very careful that in females, the presentation can be much different. It can be more centralized chest pain going into the jaw, into the neck. So not as classically localized on the left side like the picture shows here. Some people sometimes feel it more epigastrically, so that's another potential manifestation. There again, we'd have to differentiate that from GERD, gastroesophageal reflux, as well as peptic ulcer, gastritis, and so forth. The pain could be associated with shortness of breath, nausea, vomiting, diaphoresis, and lightheadedness. So that's the classic stable angina pattern. Unstable angina would be essentially when the atheroma that's growing there in the coronary arteries ruptures, forms a thrombus on top, and this can proceed into a myocardial infarction as that thrombus completely obstructs blood flow immediately, and that would be a medical emergency. This basically would be severe or rapidly progressive anginal pain. So they've had angina and it just seems to be getting worse and worse and worse. It's new onset angina, this time at rest. That's always a big red flag. They've had angina, but now they're getting at rest. They need to be evaluated immediately. Nocturnal angina, they wake up at night with chest pain, and the symptoms are not relieved by rest or nitroglycerin. That's unstable angina. And then there's a fairly uncommon variant. It's called Prinzmetal's angina. And this is caused not by atheroma formation, but by coronary artery spasm. So the coronary artery actually goes into acute spasm. And this is typical in younger females, worse usually early in the morning or at rest. This also causes substernal chest pain, but the attacks are related to physical activity, their heart rate or blood pressure, sometimes related to stress. And usually this is relieved by nitroglycerin or calcium channel blockers as medication. And there is actually on the EKG, the ST segment elevation, but no cardiac enzyme elevation like you would see in a true myocardial infarction. Remember, those cardiac enzymes elevate as the enzymes that are normally found in those muscle cells spill out into the blood. So that would be variant angina. The assessment would be basically what I went through in the last slide, so I won't review that here. We do the same kind of test, but the EKG, cardiac enzymes would be a really important test to do for that. The treatment would be for acute management. If a person has new onset, angina, or they have unstable angina again that's getting worse, they're waking up at night, it's happening at rest, immediately they need to be sent to the emergency room, emergency department, and they would essentially monitor their cardiac enzymes. They would rule out MI, and typical therapies would be to give aspirin. That is going to decrease platelet aggregation, decrease the thrombus formation, give oxygen, nitroglycerin, usually intravenously, and morphine to relieve pain. So that would be acute management. Chronic management, typically patients with angina, stable angina, will be given nitrates, and that would be again the nitroglycerin or the others I talked about in the previous videos. And these are done typically sublingual. There are transdermal forms, but they're immediate acting. They cause immediate vasodilation, so they'll relieve the chest pain. But beta blockers would be another medication that would be given more long-term. This decreases the sympathetic tone, decreases heart rate again, blood pressure, cardiac contractility, and ultimately that results in a decreased need for myocardial oxygen. So first-line therapies would be beta blockers like atenolol or metoprolol. Calcium channel blockers would be another major a medication used for angina, stable angina in particular, and that would be they would basically decrease contractility and afterload by causing vasodilation in the peripheries. Um, and they also act as coronary artery vasodilators. And these would be typically the dihydropyridine calcium channel blockers, so things like diltiazem and verapamil. So these would be typically used after, if the patient wasn't responsive to the combination of nitrates and beta blockers, it would be used after that. Aspirin is typically given to decrease the risk of MI. And then if they have any heart failure, they might be given diuretics and ACE inhibitors. And then reducing the risk factors are very important, and that's what can be focused on in adjunctive care. So decreasing smoking, the cholesterol, hypertension, and then again, focusing on any type 2 diabetes. And then procedures that are done for, definitely the unstable angina. Potentially stable angina would be the PCI or CABG. There's some interesting data on this suggesting that a lot of the effects are actually placebo. So there was an interesting study. Patients with stable angina, they were given either a placebo procedure. They thought they were getting a stent. They were put under anesthesia. They put the catheter in, but they didn't actually put a stent in. And then the other half actually got a stent. Turns out, in terms of the long-term outcomes, both groups had improvements, and the improvements didn't differ. So this was this was an actual surgical procedure, and they found that there was no real difference between actually doing the stent placement versus not in angina. It's going to be different in MIs, although even there, some are beginning to question the use of stents, but that's something to think about, that it is sometimes commonly given, but I think the best approach for these patients is to work on reducing all of the risk factors, if at all possible, to support them with the proper herbal therapies, and to really work on decreasing the excess sympathetic tone. And there's a lot through acupuncture and lifestyle and meditation and whatnot that can actually be helpful for that. So I think those are the best long-term therapies. It's unclear if the actual stenting is actually doing anything. Okay, so that's the chronic management. I'll just say for variant angina, the typical approach is to actually give magnesium, like IV magnesium, to relieve the vasospasm. So I haven't had any cases of this, but that's something where maybe oral magnesium long-term could be a helpful therapy. Okay, so that's a little bit on the different types of angina. Next, I want to talk about myocardial infarctions, acute MI, or what we just call in the popular literature heart attacks. And this is actually necrosis of the heart muscle resulting from sudden, either absolute or relative, reduction in the coronary blood supply. Single most common cause of death in industrialized nations. In the US, there are about 1.5 million MIs a year, and about a third of those patients die from the MIs. So MIs are not necessarily fatal, but have a pretty high mortality rate, but that's still a third. So 2/3 live through MIs. And interestingly, especially in elderly patients, when we do ECGs or other cardiac imaging, we often find they've had multiple MIs over the years and they didn't even know it. So you can have very small infarcts and not know it. Unfortunately, whenever the heart muscle infarcts, those myocytes die and they're replaced with scar tissue. And so over time, the heart contracts with less and less efficiency, and that often leads into heart failure. That also predisposes people to cardiac arrhythmias, especially things like atrial fibrillation, which we'll talk about later. An MI is a type of acute coronary syndrome, ACS, and this is a sudden or short-term change in symptoms related to the blood flow to the heart. Unstable angina, which is another type of ACS, is different in that in an actual MI, there are increases in the cardiac enzymes, the so-called cardiac biomarkers, and that's indicating actual cell death. Usually this is initiated by, again, plaque disruption, so rupture, ulceration of the surface of an atheroma, and then thrombosis that forms on top of that. That's our current thinking as to what causes this. Again, the elevated sympathetic tone and decreased oxygenation in the heart muscle or decreased aerobic metabolism is another theory, but they all kind of go together. The location and size of the infarct depend on several factors. The ECG is actually a good indication of which part of the myocardium is involved. I'm not going to go through how to interpret ECGs to show you which part of the myocardium is affected, but that can be read from the ECG. And then angiograms will actually reveal the actual areas of obstruction in which coronary arteries are affected. I had already talked about this in the physiology section, but remember the most common coronary arteries that are occluded in an order of their occurrence would be the left anterior descending artery. That's up to half of all MI cases. Right coronary artery would be another 30%, and then the left circumflex artery. And often when patients will have an MI, they go in for the angiography, they'll find there are actually 3, 4, 5 areas of occlusion. Generally 1, 2, maybe up to 3 areas of occlusion will often be treated with a PCI. They'll have a stent placed in those 3 areas. If it's more than 3 areas, they typically will do a CABG, which is the open heart procedure, and they actually cut out those sections of occlusion, and they usually sew in a vein to replace it. So that's kind of the most common areas of occlusion. The pathophysiology occurs in stages. So the initial stage, which lasts up to 48 hours, is basically acute inflammatory cell infiltration. So the heart muscle has died. It's starting to undergo necrosis. And so you actually get all sorts of neutrophils, macrophages moving into that area. That takes up to 2 days to happen. The dying cells will release all the different enzymes and proteins. So that's where our cardiac biomarkers go up. So creatine kinase, and then the cardiac troponins. Remember, troponin is part of that, the actin myosin complex that helps the muscles, the cardiac muscle contract. And then these all can be measured in blood tests. From 3 days to 3 weeks, the tissue is gradually, if the person lives through that initial MI, that area will replace with granulation tissue, then the tissue undergoes necrosis, and the fibroblasts move in, they start to secrete collagen, causing fibrosis. And then up to 8 weeks after the MI, that area becomes fibrotic, and by 8 weeks we see a scar that's formed in the area of the dead tissue. There's 2 types of MI. So again, as I mentioned, we can have a subendocardial infarct, and this is basically what we call a non-STEMI, non-ST segment. So again, if we look at our ECG tracing, our classic P wave, QRS, remember P is depolarization of the atria, QRS is depolarization of the ventricles, T is repolarization of the ventricles, and U is sometimes found, not always, on the ECG. But basically, an ST segment elevation is when the ST segment, instead of going down like this, actually goes up. So we have this sort of elevated ST segment. So that's a classic sign of myocardial ischemia and infarction. And so that's one thing that we look at there. So our subendocardial infarcts typically do not have the ST segment elevation. So the ST segments look flat like this versus, and again, they're occurring more in the inner side of the heart chambers. And then the transmural infarct, the so-called ST segment or STEMIs, ST segment elevation MIs, will have that elevation there. One thing I'll remind you, remember the cardiac conduction pathway, we have the right and left bundle branches that come down the interventricular septum, and they go up as the Purkinje fibers. And remember, the Purkinje fibers are going right through the subendocardia. So they are very affected by subendocardial ischemia as well as obviously infarction. And that can trigger very dangerous cardiac arrhythmias. And so a lot of people that actually have MIs die not from the heart muscle rupturing, etc. They actually die from a fatal cardiac arrhythmia that gets set up because of the blockage of the conduction pathway. So that's subendocardial infarct happening in the subendocardium. Again, this is a ST segment, a non-ST segment elevation. And usually the infarcts occur only when the smaller coronary arteries are occluded. And this has usually a good initial prognosis, but again, there's an increased risk of arrhythmias in the days to weeks following. So as we'll see, the danger of MI is not the immediate danger necessarily, but it's what happens in the days to weeks following as that inflammatory process is set up. All sorts of different changes in the electrical conduction of the heart and so forth can occur. The transmural infarcts, again, go all the way through the wall. Usually they involve the entire wall of the ventricle. And we call these Q-wave infarcts because you see an additional what's called Q-wave on the ECG. Usually develop over 3 to 6 hours after the initial onset of chest pain. Usually these have a much poorer prognosis. If a patient survives the initial MI and any arrhythmias and complications from that, the heart muscle, just depending on how much muscle is lost, will stop contracting effectively, and this will eventually result in heart failure, which we'll talk about at the end of this video section here. So those are the two types of MIs, non-STEMI and STEMI. In terms of presentation of, what's the pain like in a myocardial infarction? Well, it's severe chest pain, angina. Usually patients will have a very ashen appearance. They'll have low blood pressure, and their heart will be beating rapidly, tachycardia, to try to maintain perfusion. It can occur suddenly, or it can actually build over several hours or days. I've known people that have actually gone for days thinking they had a heartburn, and they're actually having an MI. So eventually, when they realized it wasn't going away, they sought help. It can occur with profuse sweating, nausea, vomiting, shortness of breath. Again, it could feel like heartburn in some patients. 30% have what are called atypical symptoms. This is more common in females. And then in those over 75, about 5% have silent MIs. They actually don't have chest pain or anything, but they might develop an arrhythmia or something, and then when they are evaluated for that, it's been discovered they had an MI. 20% of MIs in general are actually silent. So that's, again, routine ECG is going to reveal a past MI, but no associated symptoms. And again, this is going to be more common in the elderly and more common in patients with hypertension or diabetes. They're more prone to silent MIs. Here is kind of a picture of the typical distribution patterns of chest pain. Notice it's kind of variable. It can be in the upper back. The dark red is the most common area, and that's central chest going up into the neck. But typically left arm pain, again, that's going to be a presentation of a typical MI. That's not going to be atypical. Sometimes going into the right arm, so just because it's on the right side doesn't mean you're not having an MI. And then epigastrium as well. So again, some people might confuse this with having heartburn. The ECG is diagnostic in about 85% of cases. And again, we'd see the difference between the STEMI and the non-STEMI based on the ST segments and the T waves and so forth. And then our cardiac enzymes would be the other test that's run. Again, this will be in the emergency room. Creatine kinase, CKMB, that's going to rise within 3 hours of the infarct, and that returns to baseline within 2 days. This is not so specific to the heart muscle, so it's not the best test, but it's done in conjunction with the cardiac troponins, cardiac troponin I and T, and these rise within 3 hours of the infarct and then return to baseline only after about 10 days. So patients coming in a couple days, if they wait a couple days after the onset of chest pain, the cardiac troponins will be elevated. If the chest pain happened an hour ago and they immediately present to the emergency room, then the cardiac troponins might not be elevated yet, and so they'll actually wait and watch that patient over the next few hours to see if they elevate. The complications of MI, we can kind of summarize them with the acronym Darth Vader. So basically, death is our most concerning complication, and that would be usually within hours, due usually to a ventricular fibrillation. That's due to the blockage of those Purkinje fibers and their conduction pathways. Other arrhythmias, again, ventricular tachycardia fibrillation, atrial flutter fibrillation, and the greatest risk is within the first 2 days after the MI. Cardiac rupture, and this would be the greatest risk within 3 to 5 days, so just under a week. And that's actually where it ruptures through the entire ventricular wall, and we get blood pouring into the pericardial cavity. It can also cause rupture of the papillary muscles, which, remember, anchor the AV valves, so the tricuspid and the mitral or bicuspid valve. And as a result, that can cause valve disturbances like mitral regurgitation or something like that. So sometimes people develop after an MI, if they survive it, abnormal heart sounds from a valve incompetence because of rupture of the papillary muscle. Cardiac tamponade, that would be from pericardial effusion, heart failure, valve disease, as I just mentioned, the mitral incompetence, aneurysm of the ventricle, something called Dressler's syndrome, and that is pericarditis that occurs within 2 to 4 days after the MI, and that has to do with the inflammatory response that gets set up in the heart muscle as a result of the infarction. The formation of emboli, so you can develop a mural thrombus that forms on the wall of the ventricle, and this can embolize to the brain, causing a stroke. So on top of the MI, now the patient has a stroke, and so that's another complication. And then having a recurrence or, again, continued mitral regurgitation. So this would be the complications, Darth Vader, just to kind of keep in mind that it's not an immediate thing. It's often in the days to weeks following an MI that we sometimes see the most devastating consequences of that. The prognosis is going to be worse in any patient who has an ejection fraction of less than 40% on the echocardiogram. Remember, a normal ejection fraction should be between 55, somewhere around 70%. So if you're dropping below 40%, that's a very poor prognosis. Okay, so that's a little on the assessment and the complications of MI. So I just want to kind of go over here what the treatment for MI is so you understand what happens when patients go to the emergency room. For both STEMI and non-STEMI, the classic kind of approach is going to be to start aspirin. And we actually, in bigger clinics, we actually have a emergency kit where we have aspirin available. This is usually a high dose aspirin. Oxygen, they're given nitroglycerin to try to dilate and open up the coronary arteries to increase perfusion. IV heparin, which is an anticoagulant, and then beta blockers are given to decrease the incidence of ventricular arrhythmias and to decrease reinfarction. So that's going to be the common baseline therapy for all MIs. STEMIs are going to be if a person is going to be rushed from the emergency room, usually to the angiography, the cath lab, and they'll have the angiogram and they'll see where any blockages are found. If a patient presents within 12 hours of symptom onset and they're actually able to undergo a PCI within 90 minutes of presentation, they'll be given the PCI. If it's been longer than that, then sometimes they'll just give fibrinolytics like streptokinase, urokinase, tissue plasminogen activator to break up the clot. So that is the STEMI. Non-STEMI or unstable angina. Basically, the treatment is going to be the PCI is usually not indicated. The patient's going to be more monitored, and they'll be given additional antiplatelet agents like the Plavix, clopidogrel. They'll be given IV infusions of anticoagulant medications, and then there are direct thrombin inhibitors that can be given as well. So that would be the kind of approach, is more working to decrease, increase further thrombosis, and then hopefully letting the heart reperfuse. Now, this is where some adjunctive therapies could be interesting. Again, we don't really have the opportunity to use those in the emergency rooms and whatnot. We have some interesting data that's come out, for example, around cayenne pepper. The cayenne pepper actually is a very potent vasodilator. It also protects endothelial function, and I have heard anecdotal stories of people right as they're developing an MI drink a whole ounce bottle of cayenne pepper tincture, and that immediately reperfused the heart, and they were able to abort the MI, and they had very little myocardial muscle damage. So that's something that's interesting. We also have anecdotal stories of in acupuncture using the heart meridian on the little finger. So massaging that or vigorously stimulating that has been reportedly improved or brought people out of the acute MI quickly. So those are some possibilities that could be researched in the future. But right now, these are the typical biomedical approaches. Long term, when the patient is discharged, if they survive the MI, they have no real complications that we talked about, then we're going to definitely want to look at modifying their risk factors, I won't go through all that again. Look at antiplatelet agents, like making sure they're on aspirin, clopidogrel, Plavix. That's been shown to improve outcomes, especially in non-STEMI patients. Most patients that have had an MI will, for several months after that, be on beta blockers. They will also most likely be on statin medication. In fact, the guidelines for statins are if you've had an MI, you're pretty much on a statin. So that's the statins, ACE inhibitors, and ARBs to regulate blood pressure. They also have some beneficial effects on the cardiac myocardium. And then some patients might need an automated implantable cardioverter defibrillator, an AICD. So those would be patients with very poor left ventricular function, again, usually under 40% cardiac output. So this is implanted, and this defibrillator will automatically fire when the heart goes into an abnormal cardiac rhythm or if it slows too much. So that's going to be for the more advanced cases of MI. But when you see patients that have had an MI, it's going to be important to kind of look through what they're actually taking and understand, why they're being given these medications. Okay, so that's it for myocardial infarction. Hope that gives you an idea of kind of the clinical presentation, what the pathophysiology, what actually occurs immediately in the days and in the weeks that follow, a bit about the complications, assessment, and now we just reviewed the treatment. Finally, we'll talk about heart failure. Now, heart failure is kind of the end stage from a number of different cardiac diseases. This is kind of the end stage of what can happen with uncontrolled hypertension in some patients, with valve issues, with if they've had an MI, they can all progress into heart failure. Now, there's different terms given. So HF is just the abbreviation for heart failure. You might hear the word congestive heart failure. By definition, that actually means when both the right and the left sides of the heart fail. What's interesting is we can develop left heart failure. In other words, that involves just the left ventricle, or right heart failure. Remember, we've talked about that already. That can be, that is cor pulmonale, related to pulmonary disease. And they can occur independently. Typically, though, chronic standing left heart failure will cause right heart failure. And actually, the most common cause of right heart failure is left heart failure. But then they both fail together, and then we say the patient just has congestive heart failure, CHF. So that's both left and right heart failure. So heart failure is the inability of the heart working at normal or elevated filling pressure to pump enough blood to meet the oxygen requirements of the body's tissues. That's the typical definition. The heart is unable to eject the volume of blood delivered to it. It becomes engorged with blood, and in many cases, again, it's the end point for serious heart disease. It affects about 1% of the total US population, which is a pretty substantial number. 10% of those 65 or older. Now, as we'll see, there's different stages of heart failure. A lot of people have heart failure, but they have a very early stage. It doesn't really significantly affect their life and so forth. The later stages of heart failure pretty much are fatal unless a person is given a heart transplant. 50% will actually die from the congestive heart failure within 5 years. So here's a picture on the right of heart failure. There's a normal heart. So we get the left ventricle nice and muscular. With heart failure, the ventricle usually becomes dilated, can also become thickened. And again, when it thickens, hypertrophies, it becomes less able to pump the blood. And the volume that's ejected from the ventricle into the aorta is diminished. So that is heart failure. Now there's different types. We can have acute heart failure. So kind of you have an MI and then immediately the heart goes into failure. But most typically we have chronic heart failure. And again, that could be either the left or the right side or both. So that happens typically as a result of long-standing hypertension and so forth. I'll go through those causes here in a bit. We can have what's called high output heart failure. And that's due to increased cardiac output needed for peripheral tissues. So in chronic anemia, pregnancy, hyperthyroidism, aortic insufficiency, the heart is still not meeting, even if it's pumping at maximum capacity, it still has high output, but it's not meeting the body's oxygen demands. And that is actually a type of heart failure. And this can rapidly lead to heart failure, especially if a patient has underlying heart disease. So eventually the heart stops pumping efficiently and you degenerate into heart failure. So those are the three basic types of heart failure: acute, chronic, and high output. Now I said that heart failure can be either the left or right side. Let's look at the left-sided. That's going to be the most common. There are two major causes. So either the ventricle doesn't contract adequately, and that is called systolic dysfunction. It can also be due to massively increased afterload. So in other words, the pressure in the arterial system is elevated, like in chronic hypertension. So either due to impaired contractility or increased afterload. Or there can be diastolic dysfunction, and that is where the ventricle is too stiff and does not relax to fill adequately and diastole. So there's decreased compliance. So those are two types of left heart failure: systolic or diastolic. Systolic is the most common, but you can have either one. You can have both over time too. What happens is the left ventricle begins to dilate, it overfills with blood. The blood then backs up into the pulmonary tree, into the lungs, and then it basically starts to leak out into the alveolar spaces and whatnot, and we get pulmonary edema. So it's not the blood that leaks out, but all of the plasma leaks out. So the fluid leaks out into the alveolar spaces, and we get pulmonary edema. We get decreased cardiac output, then that leads to decreased organ perfusion. What happens then is the kidneys get less perfused. They're going to start secreting renin, activating the renin-angiotensin-aldosterone system. I won't review that here. Be sure you understand that. And then that's going to increase fluid volume because of the increased aldosterone and angiotensin 2. And that's going to worsen the heart failure. So there's going to be more fluid that builds up in the body, in the vascular tree, that the heart can't move around. The typical clinical presentation here would be any dyspnea on exertion, that's shortness of breath on exertion. Orthopnea is basically shortness of breath at night when you're laying down, and especially if you wake up in the middle of the night with a cough, patients have to sit up in the bed. All of that is indicating that the blood is backing up into the lungs due to the left heart failure. We sometimes call this paroxysmal nocturnal dyspnea. That's basically, paroxysmal means sudden, unexpected. So you just suddenly wake up at night and you have shortness of breath. There's decreased renal perfusion, unfortunately, during the day, and then at night, actually, as your sympathetics relax, you get increased perfusion, and so you start to have a lot of urination at night. There's often an S3 heart sound. Remember, that comes right after the dub and lub dub, or an S4 heart sound right before lub and lub dub. And this could all indicate left-sided heart failure. There can be pulmonary rales. Again, rales are crackles, indicated that basically is telling us that the alveoli are popping open due to the excess fluid. And then there can be cardiac hypertrophy, where the point of maximal impulse, which is normally in the fifth inner space, just below the nipple line, is shifted downward and much more to the left. That means the left ventricle is enlarging, and that's a sign of cardiac hypertrophy. So that's the presentation of left heart failure. Right heart failure, again, the most common causes would be left heart failure. It could be cor pulmonale from chronic pulmonary disease like COPD or pulmonary hypertension, or it can be from a pulmonic valve disease. Could also be a tricuspid valve disease, but basically pulmonary valve disease. The pulmonary valve is where the right ventricle has to push the blood through the pulmonary valve into the pulmonary artery. And if there is stenosis of that valve or any regurgitation, that's going to decrease the output, and that's going to lead to right heart failure. The symptoms here are a little simpler. The blood actually backs up in the venous tree, not so much the lungs, but the venous tree. And a classic finding of that is jugular venous distension. So here's the jugular vein. Patient is resting at a slight incline, and you can see the actual column of blood going all the way up in the jugular vein. And we can actually use the top of the sternum, and we could measure how far up it actually is going, and that can measure the severity. So that's jugular venous distension. And the presentation here will be, again, anything associated with the venous system. So we might see pitting edema. This is a cause of the low protein transidate we talked about, causing pitting edema, so heart failure, especially right-sided. Pleural effusions, as well as ascites, jugular venous distension. Again, that's what I just showed you in the picture. And the large spleen, splenomegaly, and in the large liver, we call that a nutmeg liver. So all of the venous blood can't drain out of the liver. It gets backed up because everything's backing up in the vena cava. And this causes very characteristic histologic changes in the liver that if you do a liver biopsy, you can see. But this usually results in ascites. So that's the typical presentation of right heart failure. Now, congestive heart failure, again, is when you get both. So you're going to have basically both these presentations. You're going to see the lung issues as well as all the venous congestion. So that's the differences there between left and right heart failure. Now, because left heart failure is more common and it's often the initiating event of congestive heart failure, let's look at the different types in more detail. So I talked about systolic and diastolic dysfunction as two causes of left heart failure. So systolic, we get decreased ejection fraction, decreased contractility, and increased end diastolic volume. So basically the blood just remains in the ventricle. It's not being ejected. Basically, this is due to either decreased contractility, and there can be a lot of factors that decrease the contractility of the left ventricle. So ischemic heart disease is the most common. Patient had an MI and that caused scarring in the heart muscle. Valvular heart disease, hypertension, chronic hypertension, arrhythmias, the different cardiomyopathies. These are diseases of the heart muscle itself, not due to coronary artery disease. Any toxicity, so we know that chronic alcoholism can actually lead to systolic dysfunction. Having high catecholamines, cocaine use, etc. Arsenic actually has been correlated with systolic dysfunction. We suspect different viruses like Coxsackie virus, different adeno or paroviruses, and so forth. And then there are bacterial causes, Staph aureus. This usually is because the bacteria infect the heart valves, and that causes a heart valve issue, which leads to the decreased contractility. Even different parasites have been correlated with this. Fungi in immunocompromised patients, systemic autoimmune disease like lupus, and amyloidosis. So these would be all the typical causes of decreased contractility. There can also be increased afterload, and the most common reason for that would be hypertension, as I mentioned, but also aortic valve stenosis. So another cause of increased afterload would be an increased chamber radius of the left ventricle, and that can occur in dilated cardiomyopathy or valve regurgitation. So those are the two common causes of the systolic dysfunction, either decreased contractility or increased afterload. Now, what happens, the body tries to compensate for that. And so the Frank-Starling mechanism kicks in, again, to try to maintain some of the cardiac output. Remember, Frank-Starling is the more you stretch the myocytes, the stronger they contract. So as you get more blood backing up and filling into the vascular system, it fills the left ventricle, stretches it, and so Frank-Starling up to a point can maintain your cardiac output, but over time that begins to fail. The heart begins to enlarge, and then your sympathetic nervous system kicks in to just try to whack the heart. You start secreting more norepinephrine as well as adrenaline in the blood to try to really stimulate the blood, the heart muscle. But that over time results in further metabolic changes in the heart muscle, and you start going into anaerobic metabolism and so forth. So that has diminishing returns. So as we'll see, some of the main medications to treat heart failure are actually medications to cut off or block or stop the adrenergic stimulation, like the beta blockers, as well as the ACE inhibitors. So we'll see those are very commonly prescribed for heart failure, especially for left systolic dysfunction. Diastolic dysfunction is a little bit easier. This is again where the heart muscle is not relaxing, and that's actually due to the calcium not being properly regulated in the myocardium. This is basically where we just get decreased compliance, so the ventricle can't fill with blood. Typically, there is a preserved ejection fraction, so the contractility is still working. So what ends up going into the ventricle is still able to get out, but it's not able to fully relax and fill properly. And that can be, again, due to intrinsic problems of the myocytes, due to the decreased calcium reuptake. as well as just abnormally stiff ventricles that occur typically when the ventricles hypertrophy or we get amyloid deposits and so forth. This is, again, much less common than the systolic dysfunction. All right, so those are the two main types of left heart failure. It's what happens when the cardiac output starts to fail is that, so we have decreased cardiac output, we have activation then of the sympathetic nervous system, as well as the renin-angiotensin-aldosterone system. Those two systems try to whack the heart into pumping more efficiently. And that is effective, sometimes for years. But then over time, the left ventricle starts to hypertrophy. And then the blood starts to pool in the ventricles dilate, become stretched. Again, that Frank-Starling mechanism should kick in to try to maintain cardiac output, so we call this compensated heart failure. So we have a temporary, all these mechanisms kick in and they maintain normal cardiac output. Over time, though, the Frank-Starling mechanism fails, and then we get uncompensated heart failure. And then both the right and the left right and left side of the hearts begin to fail together. So that's the typical pathophysiology of how CHF evolves. So just to give you a little idea of what the biomedical assessment for heart failure is, well, history, physical exam are important. There are specific criteria for heart failure called the Framingham criteria. They can be looked up online. They can give you an estimate of how likely is heart failure in a patient with specific signs and symptoms. Special tests would be a chest x-ray. This is a very helpful test, very inexpensive, but you see some characteristic signs. So one is you see normally the heart, which you see the cardiac shadow over here, should only occupy about half of the space in that lung. Notice that it's really enlarged. It's going all the way almost to the end here. So we have an increased size of the heart. We're also seeing evidence of pleural effusion, as well as these little lines, again, indicating pulmonary congestion called curly B lines. This is a very classic finding in heart failure, and especially left-sided heart failure causing pulmonary edema and pleural effusion. Echocardiogram would be our gold standard. Again, our normal ejection fraction is about 50, 55%, up to 75%. And in systolic failure, the ejection fraction falls below 40%. That's the systolic failure. And then diastolic failure, the ejection fraction is normal. So we actually maintain a normal perfusion rate there. So that's systolic, diastolic, and echo can help us differentiate that. The ECG would be helpful to detect any potential arrhythmias that are resulting from the heart failure, whether or not ischemic heart disease is maybe contributing to this, and then it can show us evidence of cardiac hypertrophy. And then our typical blood tests would be our standard test to look at cardiovascular risk factors and so forth, pulse oximetry to see how much oxygenation is actually happening in the body, and then cardiac enzymes if an MI is suspected. But there is actually a very specific blood test for heart failure, and it's called the NT-proBNP. So BNP, B-type natriuretic peptide, is secreted by the ventricles. It's also secreted by the brain, and it was first discovered in the brain. That's why it has the acronym B. But basically, NT-proBNP is going to be secreted as the ventricles enlarge and hypertrophy. And so we can actually use this as a biomarker for heart failure. So just know that there is a blood test together with all of the other, the X-ray, the ECG, the history and physical exam. And based on the patient's age, we can look at the NT-proBNP levels less than 300. Basically, that's going to indicate that you have congestive heart failure is unlikely. If it's with different age groups, you can see the different numbers here. That's going to say that, we're going to look at other causes. But if the numbers of pro-BNP go over 450 for anyone under 50, over 900 for those between 50 and 75, and over 1800 picograms per milliliter for those over 75, then heart failure should be a consideration here. So that is a useful test to kind of add on there. Less commonly tests that would be ordered would be things like nuclear stress tests, the angiography, and then ventriculography. That's called a Muga scan, and that would actually allow with a radioactive tracer to visualize the chamber sizes and their function and so forth. Now, a very important thing we do with heart failure in the biomedical settings is to classify the heart failure. And there are 4 stages, and there's 2 different systems that are used. One is by the New York Heart Association, the other is the American College of Cardiology, American Heart Association. And so we can classify people as in the ACC AHA guidelines as either stage A, B, C, or D. The New York, we have class 1, 2, 3, and 4. They kind of overlap a little bit. Basically, I like to use the New York Heart Association because it's a little easier. But the class 1 is basically where people have some of the evidence of heart failure on the physical exam, on the different tests that we do, but they have no limitation of physical activity. They can go upstairs, they can exercise, they're not showing any problems. Class 2, we see a slight limitation of physical activity, but they're comfortable at rest. If they go upstairs, they might get winded a bit. That's about it. Class 3 would be marked limitation. They really can't exercise. They have exercise intolerance, but they're still, if they rest, they maybe do some exertion, they rest, they feel better. And there's some subclasses here, type 3A, there's no dyspnea at rest. Type 3B, we're seeing some dyspnea that's increasing at rest. And then type 4, class 4, is basically inability to carry out any physical activity without discomfort. And the symptoms are even present at rest. So these are all indicating various stages of heart failure, various degrees of severity. And so this is helpful for determining treatment, how aggressive should treatment be, and can also help to estimate, where a person is in the whole pathophysiologic evolution of heart failure. So that's a little bit about the assessment of heart failure. So the treatment for heart failure, our goals are basically to increase cardiac output, to decrease pulmonary and systemic congestion, to slow and reverse any cardiac remodeling that's occurring, and if there are acute exacerbations, to manage the acute symptoms, and that's called acute decompensated heart failure. So you have a person with chronic heart failure, now they get an acute exacerbation, that's the acute heart failure. And then address anything that might be predisposing a person to the heart failure, like longstanding hypertension, thyroid disease, alcohol abuse, etc. Unfortunately, even with proper treatment, the prognosis is usually very poor with heart failure. Usually the patient decompensates over time. There's a marked decrease in the quality of life, and the overall annual mortality rate in patients with heart failure is about 10%. And there's a high risk of ischemic stroke in these patients as well because of the turbulence of the blood going through the heart, increasing the risk for thrombi. They can embolize. So the approach is really starting with level 4 therapies. Now I put level 1 and 2 because I have a number of heart failure patients where they are appropriately addressed with level 4 therapies, and I'll review them here in a second, but they want additional care. And we're really focusing on some of the risk factors like with the hypertension or whatnot. And that's where dietary restriction of salt is thought to be very important to decrease blood pressure, as well as in this case, you want to be sure the patient is not over consuming fluids. People often recommend, lots of water and, so much water per kilogram of body weight, etc. Here, you got to be careful because you could very quickly overload them with fluids. And so fluid restriction is usually what we aim for. Now, exercise is still indicated, especially for the earlier stages, if they can do it, because any exercise will actually will improve resilience in the heart muscle. Decreasing alcohol, basically eliminating alcohol and smoking, and weight control are very important measures, and then stress reduction can be important as well because we often see, again, an overactivation of the sympathetic nervous system, and so anything that could increase the parasympathetic tone would be helpful. Level 2 therapies would essentially be addressing your cardiac patterns. If you're in Chinese medicine, your herbal patterns, and we already discussed those with chest pain. And there are a number of different herbs and agents I just listed here that might be very helpful as vasodilators, like hawthorn, either the leaf, flower, or berry. Hawthorn has very similar effects to ACE inhibitors. Arginine is the amino acid that is a precursor to nitric oxide, so a vasodilator. Berberine, coleus, and that's especially helpful in cardiomyopathy. And there's unclear evidence for these agents listed here. But that's just a little bit about how we can address level 2, supporting salutogenesis. But level 4 is kind of the primary biomedical approach, and that is, for example, if a person has acute decompensation, to support them with oxygen, vasodilators, diuretics like the Lasix talked about, the furosemide, very, very potent diuretic to get fluid volume out of the body. Some pathomimetic therapies like dobutamine. So this is, again, the sympathetic nervous system usually is overfiring in heart failure. So we want to calm that down to prevent any cardiac remodeling and so forth that occurs chronically with that. But in the acute sense, using vasopressors might be needed, like IV dobutamine, which mimics your sympathetic nervous system. And then morphine sulfate, both for pain and anxiety that come in patients as they're, if they're drowning in fluids from the heart failure, that creates a lot of anxiety. But morphine also has a effect on dilating your veins, and that can decrease the preload, the blood coming back to the heart, the venous return. And so that can be helpful in the acute setting. But chronically, the first-line agents, which we now have good data that they actually decrease mortality, they prevent cardiac remodeling and hypertrophy, are basically the ACE inhibitors and ARBs and the beta blockers. So these would be our classic first-line agents. Now, this would be typically for systolic dysfunction, no evidence yet for diastolic dysfunction, but basically for systolic dysfunction, ACE inhibitors and ARBs like enalapril and valsartan, or beta blockers, and this is going to be things like metoprolol, carvedilol, bisoprolol. So these would be typical heart failure medications. Aldosterone antagonists, remember aldosterone, secreted by adrenal cortex. This is in response to angiotensin II, so it's secreted in response to renin and the whole renin-angiotensin system. And its effect is to cause the kidneys to retain sodium and fluid. And so if we block aldosterone, we should urinate out more. And these are basically the potassium-sparing diuretics. I already reviewed those in the medication section. These would be for much more advanced heart failure. And so spironolactone would be an example there. Vasodilators for patients who are intolerant to ACE inhibitors like hydralazine, isosorbide dinitrate. And then, so all those would be first-line agents that might be considered for heart failure. Typically, the first two, the ACE inhibitors or ARBs and the beta blockers, would be the most commonly given. Second-line agents show no mortality benefit, but they can address symptoms. So digoxin from digitalis can address atrial fibrillation and left ventricular dysfunction. Basically, it's just going to help the heart to try to increase contractility up to a point. And then diuretics, the loop diuretics and thiazides. I had mentioned a few videos ago about this idea of how do we increase the parasympathetic responses in the heart, and that is where the awabane or the strophanthus could be of use. It's not really used in the US, but again, in Germany, it is used frequently for heart failure. And so that's an interesting one to consider in patients. Other potential therapies for heart failure would be implantable defibrillators for patients with very low ejection fractions, cardiac contractility modulation, that's another electrical stimulation on the heart muscle to make sure it remains beating. Ventricular assist devices, try to assist the circulation in the left ventricle. Cardiac resynchronization therapy, again, another electrophysiology device. But ultimately, patients who progress to stage 4 heart failure, they are very symptomatic, even at rest. They're really decompensating. If they're candidates, they'll be put on the list for a heart transplant. And then for patients who don't qualify or who fail the heart transplant, the approach is usually palliative care. So this is where, patients with heart failure, if we can work with them adjunctively, that would be wonderful to maybe support them. Unfortunately, by the time they present with that more advanced heart failure presentation, their heart muscle has undergone so much remodeling and change, we don't know yet of anything that can really reverse that. So this is where with heart failure, we want to really try to target early we want to really address those risk factors. And that's why we put such emphasis on things like reducing hypertension and type 2 diabetes and things, because we know they all can help prevent the onset of heart failure. Okay, so that wraps it up for the first section here on cardiac diseases. We looked at ischemic heart disease as well as heart failure. In the remaining videos on cardiac disease, we'll look at cardiac arrhythmias, valve diseases, cardiomyopathies, and then pericardial diseases. And then we'll be finished with the entire cardiovascular block.